get started. We'll stand and have a prayer and a pledge of allegiance, if you don't mind. Dear Heavenly Father, we thank you for this beautiful summer day and for a chance to be here and to review our county insurance. Just thank you for these professionals in this field that help us with these important decisions, and I pray that you will guide and direct us to understand this complex stuff and to make wise decisions that are appropriate for this county. Just preside over this meeting for us and guide us through it. In Christ's name, amen.
Amen.
Pledge. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
For our guests in the audience, mainly what we're going to do today, Brian, will be to review the last quarter of the performance of our insurance. This is more geared toward telling us how our plan has done. We may have some time at the end where we'll discuss any changes that we might make to this, but I'm not guaranteeing that that'll be part of this discussion. But if you have any questions in the meantime, I will let you all ask questions. Maribel, you too, okay? All right. Thank you to our guests for being here. Chris, thanks for driving in today. Thank you for always putting together a good, concise overview. So I'll turn it over to Steve. You want to begin or let Chris get started?
I'll go ahead and let Chris get started. I'll be honest with you, I've been gone for 10 days. This is the first time I've seen the report, so I do just a quick look, see that we're running a little hotter than normal. But anyway, I'll let Chris kind of run through the review. Now, hopefully Tony will be here, and we've got that one other item that we need to discuss today, too. So Chris?
Thank you everyone for inviting us out here today. What I've presented you with is the first 6 months of the plan overview for 2016. And this report is on your medical and your pharmacy, but there's an addition there. We've done an addendum and added in a OptumRx report, which is a separate report that we'll review afterwards as well. So please feel free to ask any questions you might have to me while we're going through the report. And I'd like to start off on page 2, which is your demographic overview. This plan overview report is going to be a comparison report from the first 6 months of last year versus the first 6 months of 2016. There are some pages that do what we call a rolling 12-month, which is to give you a full 12-month picture of what the data looks like and what it means. So I'll point that out when we are on that page. So looking at your comparison at the top on the average age of the employee versus average age of your member, very, very consistent to the last 6 months and pretty close to what the UMR Book of Business normative data is as well. As you can see on your average age of your employees and then the next box, average age of your members, you have a slight growth in increase in your membership. So at this time last year, you had 131 employees enrolled. This time for 2016, you have 140 employees enrolled.
But that includes dependents?
No, the next box down includes your dependents. So there's 140 true employees, and then down below you have your members, which we show there are 225 members that are enrolled in your plan. So that spouses and children.
So that may have gone up from last year by bringing in the probation department into the plan. That's part of those numbers.
Correct.
Or part of the increase anyway.
So, I mean, the 15 employees growth in membership, I mean, is not huge, but it's a 6.7% increase. And the reason I'm bringing this up is, as Steve indicated in the beginning, we are running a little hotter than you have in the past 6 months of last year. So with additional membership, you have some potential to have additional claims coming up. So we'll go through that and what's going on with your plan that we can tell right now. So there's not much else to go through on this page. If you'll turn to page 3, This is a claims overview report. And at the top, it's giving you a total summary of, for the 6 months of this year, you've had almost $1.4 million in claims billed. The ineligible percentage has actually gone down to 120,000 of ineligible charges. Those are charges that are not covered under your plan as of today and how your benefits are set up, leaving the plan amount of being almost $103 million. Your discount was over $500,000, so about $604,000, $605,000. So after the discount was applied, the allowed amount of the plan was at $654,000. Benefit design of $104,000, that is any deductibles, co-insurance, and co-pays that the members are paying towards their benefits on this plan. And then coordination of benefits, so a spouse or a dependent that's on the plan that has other insurance, that's where coordination of benefits would apply first before the Titus County plan paid. Leaving the plan to pay in dollars $548,120 in medical expenses versus last year at this time you only had $350,000 worth of claims. So you can see that there's been it's showing a 56% change increase in claims. In addition to that, the next line shows there's been a 27% increase in your pharmacy spend as well. So I've got some recommendations, some ideas. We still have further data to gather to come back out and talk, and I'll get with Tony and Steve on recommendations of some plan designs, looking at what's driving these costs more, so we can come back to you all and make some presentations, recommendations. In looking at the payment metrics, this is where are these expenses incurring? Are they incurring and increasing on your employee side or your membership side? And actually, it's on both. So the employees have incurred more costs in addition to your membership. So you can see that of the 140 employees, last year this time, the per employee per month average cost was $449, and this year it's $656 on average.
Where is that figure?
That's down here under the payment metrics, so it's like right in the middle of the page 3. You'll see where it says average covered employees, and then right down below it's showing you a per employee per month average cost of that, and that's based on the $548,000 that was paid.
Okay.
Then at the bottom box, what we're showing here is the paid amount by paid month. So it's just breaking down how much was medical dollars paid for each month versus the pharmacy.
Will you slow down just so I can absorb this?
Sure.
Go back to the center there.
Yes.
And let me be able to understand per employee per month and per member per month. Per member includes everybody.
Yes.
So when you dilute it with dependents, I'll call them, the cost divided out by everybody is less.
Correct.
And obviously the heaviest cost is in the employees, and that we would explain that because we've got lots of kids on the plan that aren't getting sick, or we've got spouses that aren't as sick or don't have as many claims.
Very good point. And if you'll come back to page 2, you can see on the enrollment by coverage tier at the bottom box, you'll see that your employee and spouse has 21 spouses, where your employee children and then your employee family, you have 10 that are just employee with children, and then the family includes a spouse with children. And to your point, Judge, children tend not to go to the doctor unless their parents take them based on their age. So usually 18 and under, they're not going to the doctor unless mom and dad take them, or they have something, but most part they're doing their annual checkups every year, and that's about it. So back over to page 3, that's why under the per member per month, it does bring that cost down somewhat, yes.
It does appear that your biggest cost driver, though, is coming from your employee side.
Yes.
Not your spouse, your kids.
I was just trying to determine once again, that decision about are we adequately charging families, spouses, kids. But it's good to see that that group is a lower cost, which again, I would assume that it would be. I still don't know if we're charging adequately for that group, but nonetheless, we're up across the board, way up.
Well, one thing you need to also look at is your pharmacy, which is broken out of both of those boxes.
Mm-hmm.
And as she said, probably going to make some recommendations about changing the pharmacy going forward, because that's probably the biggest driver of the community group, not just y'all, but it's just skyrocketing, and it's because of the cost of the pharmacy. Pharmaceuticals are just crazy.
They really are.
But yet we're still way ahead of the norm. We're double the norm. No, not quite, but significantly higher than the UMR norm.
Yes. And some of that is due to, as Tony just indicated, there's been some push to make a lot of changes on the pharmacy side more restrictive by, and what I mean by that is, instead of a member just being able to go out and get that non-preferred drug that's being advertised now on everything, you put in some steps where they have to try that cheaper drug first, and if it's proven that that does not work, then they can get that drug, and then looking at that cost of that prescription. For example, specialty drugs, average cost now is running around $6,000 to $7,000 a script. Those Hep C drugs, which are very good because they do have a end time now to where they do cure hepatitis C, but it's a 3-month period that can run over $100,000 in just prescriptions. So it's, yeah.
Well, and we heard a real life situation yesterday. A spouse with cancer is, really being challenged on their medicine costs, it sounds like. I don't know all the facts, but I was trying to explain to the sheriff, it's not that we don't want to cure your wife's cancer, that's not it, but we have put some heavier restrictions on pharmaceuticals, and you kind of explained them there. It's not that we're just going to sit there and let your cancer continue, but we are going to try some other things before we give in to this ridiculously expensive drug if there's another way to combat that. And I'm hoping that's what part of this explanation is. I'm sure we'll find out more about that case later on.
And I definitely can look into what actions have been taken and what's being provided.
Okay.
And get back to you on that. Any further questions on page 3 at this time? Looking at page 4, what this is basically breaking that claim contribution, or distribution, I should say, down, and where are these dollars falling? Are they falling in what we like to see is the bulk of the claims dollars falling in the $49,999 and below. So in the top table is 2015's data, and then in the bottom table is 2016. And compared to last year, you did have one claimant that had already hit $200,000 and the 6-month period. You've got a claimant again that's hit over $200,000 in this first 6-month period as well. So with the exception of that outlying person, most of your dollars are running in that nice area of $49,000 and below. And Tony just asked, is this the same person? And it's actually not the same person. This is a new high dollar claimant.
Okay.
And so looking at page 5 is actually showing you your high dollar claimants. The top box is showing you how many high cost claimants did you have, and what is considered a high cost claimant is anyone who's incurred $25,000 or more in this first 6-month time period. So last year at this time you had 2, this year you now have 4 claimants. One of them has already exceeded your stop loss level, so you have already received reimbursement on those dollars that went above your $50,000 spec. But the others haven't hit it yet, but they're very, very close.
You'll notice that the relationship in that column, you've only got one employee, everybody else
say that we've only got one.
In that box below, the second box, it says high-cost claimant detail.
Yeah.
It shows you the relationship of your high-cost claimant. So you've got one employee, which is number 2. The rest of them are your dependents that are your high-cost claimants. What I don't know, and I wasn't able to hear back yet from our stop-loss folks, is this high-cost claimant, are they continuing on with claims, or has whatever the treatment and incurred done for the year, and that person is not going to incur more cost? So I will find out that information and let you all know. But the claimant number 2 and 4, they are continuing on with treatment. So there are more dollars that will occur for the remainder of this year. Page 5 is what we refer to as our major diagnostic category, and this page is showing you where are these dollars being spent and what type of diagnostic scenario. So your highest claim dollars is your nervous system, which actually coordinates to the diagnosis that was given on your high-cost claimant. So that's why that is the highest dollars for this year, where last year it was musculoskeletal. Good news, not trying to deliver all bad news to y'all, so the good news is I always like to see the health status category be in the top 5. Continues to be number 4 on your list, so that is very good news. Your folks are still getting their wellness and preventative, and I know that that was a big push for this year, because you're looking at thinking of doing something on that side of it for 2017, and they're still continuing to do that. Now, there's a page back here on the preventative. They've dropped off a little bit in the first 6 months of this year, but that could also be that there's a timing as to when you go get certain things done. So when we get to that page, don't think of it as necessarily a negative. Someone may, and that's where the time period is more rolling 12 months. So that is only through the end of March. But I'll give a little heads up on that. You're still exceeding the UMR book of business norm in getting your preventative services done. Your membership is.
So 14 more people have gone and had a preventive visit than this time last year.
Yes.
Do you see that where it's health status last year was 8?
Yeah, but that means there's a bunch that still hadn't gotten it. But
Yeah.
we got half the
Right.
year left, and some will wait till December 31st, I guess.
Well, and plus also sometimes doctors will only let you come. So if you had your annual exam for a lady last year, July 16, you can't come back and have it again until on or after July 16. So it really is, they require a full 12 months. So it is a timing of when they have to or are allowed to, or when they go and get those services done. I can tell you school's about to start at the end of August, so I'm sure in August everybody's going to take their kids out and get their physicals for sports and their annual exams and update their shot records so that they can get them back in school. So there'll be probably a big push then. And when I come back out later this year, you'll see that there's a bigger increase on your preventatives.
And as a review, what we did, Christy helped me remember, if they don't have their physical by the end of the year, we'll start off in January, and we will charge that employee $50 a month. Is that $50 per paycheck?
Per person. But like I was just talking to Tony, if somebody goes in December to have a physical, it's not going to show up in January. So we're going to have a timing difference just because January when we get somebody to start charging everybody.
Right.
It may be on and we'll just try it. If it doesn't work, if it's too much in our office, then we're going to have to do something else. But we're just going to kind of see how this goes first time.
When you do offer a standard report that's populated every month and report for those who prevented wellness screenings, so that's the annual because you had, and there's 2 different reports of one for truly wellness preventive screening, and then there's the lab work type work preventive work available.
So the first year, we're just going to have to slowly get into it.
And one thing I'd like to, as we're talking about wellness right now, I'd like to say, you don't talk about wellness, you're well-known and change.
We have to.
Okay, we'll kind of jump the gun a little bit, but we do have now that we're affiliated with sure that you're not being, that you're being legal, that you're not being discriminatory against any one set of people or group of people. And I'd like to maybe, as we get closer to renewal, maybe bring Katie or somebody over or just kind of meet and see maybe what your options are, because they will try to make sure that whatever you're doing is legit. And then you got through your plan to get there. And all that will be included with our service that it's not a cost to you to do that. So we're excited about doing that.
While she's on that particular point, we do also have on staff now a ex-Department of Labor investigator that helps with compliance. So any compliance questions that you have, or Christy would have, or Carl would have, that is included in our service. Okay, so you got a guy that's in our Fort Worth office that you can pick up the phone and call him directly and ask him any ACA questions, HR questions, anything like that. That's included. No charge for that. So,
All right.
Let me ask you this. You know, I came back, 3-4 months ago, and y'all gave me a deal that showed your age and what you needed to have checked and what you needed to do and stuff. Does everybody in the county have one of those?
Well, again, let me just answer that question, because you're talking about the benefit booklet that we produce.
Yes.
And if they attended a meeting, they got a book, right? Okay. So, yes, sir, everybody should know whether they know what the book is now. Yeah, I don't know the answer to that. But in November of last year, they all got a booklet. And in that booklet was the suggested, and again, that is so subjective. That can be different for everybody. And again, why you need to have a conversation with your own doctor to say, with my health condition and my medical history, I might need something different. That's just a suggested thing. When you turn 40, you might need a mammogram. But if you've got medical history of breast cancer, you might need to start those when you're 30. But yeah, everybody has the booklet, and we can give you more if you want to give them out.
Well, what I'm thinking, and we're all guilty of this, but you get this, and you got good intentions, you lay it down, you can't find it.
Well, what we could do is just
And two, if we had a letter that we could go with that and staple it together, let it stays together, and remind people that we need to have this done before December the 1st. I'm just saying.
The employee is going to have to take some responsibility.
Do what?
The employee is going to have to take responsibility for himself. My office, Tony and them, they're not going to have time. I mean, they're going to have to help us. We can't, because each person, each individual is different. They all have different needs. And to write one letter, you're looking at several, 120, 140 different letters to write. So,
you know, maybe an easier solution that would be just a one little sheet payroll stuff, or do you actually cut the paychecks? Okay.
And also too, the wellness thing I'm talking about, that if we may have some stock things that just say, hey, had your wellness exam this year?
Yeah.
Let me see what I can.
Well, we can send out an email to department heads that spells it out pretty clearly. You've got X number of months for all of your employees to get their annual wellness exam. And what we mean is you tell your doctor, I am here to satisfy the requirements of my insurance company to get a preventative wellness health checkup once a year. And that's what I'm here for. And
Write it out and give it to them.
well, I'm not going to give it to them. Again, we're not going to stuff envelopes. We've covered this during sign up. I'll send it to the department heads. It'll be in writing. And if those department heads will post that for those girls, if they have a question, call us. But it doesn't get much simpler. You got to have a checkup once a year, period. And if it doesn't, you're going to start paying for it. And they won't go very many paychecks at $50 a paycheck before they'll realize what we're talking about.
And for us, we talk about our other shops that we have one HR, that's Sherry, which all people will be able to do that too. But it's unheard of. We're not leaving 100% HR. So the department heads, the officials, they are going to have to start taking on more responsibility and getting involved with governance over this HR.
Yeah, but it shouldn't be a difficult script. I need an annual checkup to satisfy my insurance requirements. And I'm sure every doctor in this town understands what that means. Anyway.
Okay. Good discussions, thank you. Moving on to page 7. This is breaking down where your claim costs are incurred. By that I mean, is it at inpatient facilities, is it outpatient, or physicians? So generally when you're doing any inpatient or outpatient, you're going to incur a physician charge. And then the ancillary will include any durable medical equipment, prosthetics, or prescription drugs that are actually administered through your doctor's office. Because there are some that have to be administered in that manner. Looking at the 2016 data, on the right-hand side of this graph, you'll see that your inpatient stays have increased in the dollars, and so your average per member per month cost has increased as well, and that is due to looking at those high-cost claimants. There were quite a few inpatient stays for those claimants. Outpatient has spiked up quite a bit. Went from, paid $37,000 last year last year at this time to $109,000. Inpatient or outpatient is not bad in the sense that they're not incurring an overnight stay at the hospital, so they're going in, they're having their procedures done, and then they're leaving the hospital. The costs are less, so having that spike is not necessarily as bad as long as they're staying in network and having those services performed. Physician charges again went up, and that's due to more costs in your inpatient, outpatient. And then ancillary spiked just a little bit. There's no concern there. Well, yeah, pharmacy dollars are up as well. And we'll talk about that report in just a moment.
The graphs reflect the number of claims or the dollars?
Those are reflecting the dollars.
Well, it looks like inpatient is maybe even slightly less than last year. Why is that? Inpatient.
Yeah, you're right. I don't know. Because your outpatient shows a significant increase. Maybe because you had more outpatient, just making it 100% high. I can't answer that, but I will.
But it looks like there's less difference to it.
No.
Well, I get the fact is you've had a total jump from 489 to 724.
Correct.
And you can't go beyond 360 degrees in that, so it's not really comparing. It's more comparing the relative balance between inpatient, outpatient, physician, and ancillary, not comparing to the prior year.
It probably would be better to, instead of showing a pie chart here, more of a graph
Bar chart.
Bar chart would look much better. It's a great recommendation.
Yeah.
Moving to page 8, this is breaking down what is your inpatient summary. It's looking at your admissions. Now, these are on a per thousand basis, so you did not have 35 inpatient stays for this first 6 months. It's based on a per thousand basis ratio. So it actually, those that were inpatient, there were less admits, and the length of the number of days they stayed and the length of stay that these folks that went in inpatient was actually less. The dollars were higher, so that correlates to the condition and the type of treatment, but they were in there for a lesser period of time. So it doesn't always correlate. If you stay less, you're less dollar amounts. Your condition causes those dollars to reflect. Then down below, what type of inpatient stays were they? Were they medical, surgical, maternity, inpatient, psychiatric, and detox? What yours were 3 of them were inpatient, medical, surgical. Now this inpatient rehab, that person is also one of those 3 that was inpatient up above. They went from being inpatient in the hospital to an inpatient rehab before they got totally discharged. Our next page is continuing on with key indicators. This is breaking down, looking at emergency care, urgent care, and your office visits and labs. And what I noticed was your emergency care spiked. Now again, this is on a per 1,000 basis, but you went from 259 per 1,000 last year to 366. So, and your urgent care dropped off. Which is odd because your urgent care center opened last year, so you would have thought you would have seen a spike of folks going there versus the emergency room. What I don't have with me today, but I will get it, and I'll get it over to Tony and Steve and you all, is we now have the ability to run a drill down emergency care report that shows true emergency services versus non-true. How many people went to the emergency room when it was a true emergency, and there's diagnoses that identify a true emergency versus just going because it was convenient, because they didn't want to wait to call their doctor, they didn't want to use teledoc, they didn't want to go to the urgent care. And it will also provide you what day of the week they went. Sunday, Monday, and then, you know, hours. So we will get that drill down report and then provide that, because this is where I have a recommendation that you probably need to look at increasing your emergency care copayment.
With urgent care at the hospital, the one about Herschel's is not.
Very few urgent cares, that's
Yeah.
24 hours. Urgent care is going to have an extended stay, maybe to 9 o'clock.
Right. And weekends.
And we, yes, Sundays and Saturdays. But one of the things I want to ask is, do you have any recommendation on these emergency standalone places that are popping up that are not in anybody's network?
Oh, they're in, most of them are in our network, but they're very deceiving. So do you have one that,
There's two that are just opened up in Milwaukee.
Okay.
And they say ER on there.
Yes.
And you think that you're going to the emergency room, but you are not.
right. So those.
What are you going to?
You're going to, and some of them have urgent care /ER on them. And so how they're contracted and how they're regulated is between a set number of hours, like 7 a.m. to 7 p.m. If you go in for a condition that is maybe a sinus infection, cold, flu.
Not really an emergency.
Not really an emergency, that falls under, during those set hours, it falls under your urgent care. So they apply your urgent care copay. After that hour of 7 p.m., whatever reason you go in there, it's now deemed an emergency room because that's how they're filed. And then they charge you emergency room charges, which go way up. Now, United Healthcare's network has, for the most part, contracted with all of these providers. I just got in my email today from my boss a article about emergency care standalone centers are not truly what you think they are. And it talks about people thinking they're going in for an urgent care type of thing when it truly is falling under emergency. And that's how they're billing it. And it's
some carriers are not even covered.
yeah, it's become a huge cost factor. Unfortunately, the education piece of it, we're trying to catch up, be able to help people
that
out.
don't want to sit in the emergency room at the hospital, that they're going there for their convenience.
And it's a convenient care thing because it's standalone, it's 24 hours a day, and they think, oh, this is really not true emergency. I don't have a broken bone that, you know, I mean, they can set broken bones, but compounds or heart attacks, they don't treat. They send you to the emergency room at the hospital. But anything else, they will treat and they will charge
Do you
you.
think some of that is this?
I don't know. I've got to get that drill down report. I apologize.
Yeah, that would be important for us to know if we've got
Yes. members
that are abusing the emergency room
Absolutely.
privileges, in which case we'll start heavily docking them for that. But
Because in the past, it's been lowering, so I don't know what happened from last year to this year that caused that to spike. But we'll drill down and find
they're
out what's
emergencies,
going on.
they're emergencies.
Exactly.
If they're
And
convenience,
that's what this report will tell you is, was it a true emergency and you just had more cases of it, or was it a convenience thing and they just went there? Yes, sir.
The city has insurance, and they get, like, we do $4,500 deductible. So I've been told that, don't go that. You can avoid that $4,500 deductible by going to the emergency room.
Well, it depends on how their benefits are set up. Maybe there's for example, your benefit has a $100 copay for the emergency room. That's the most you, if you went there, would pay. And the plan picks up the entire cost after that. So it doesn't go towards your deductible.
Your $4,500. Well, why ever go to the regular doctor? Because
Well, here's what I think you're talking about, is if it is a true emergency, they waive that deductible. Is that a possible
That's the
item?
possibility of the plan design, yes. I've seen
But
that.
if they show up there and use it like you're talking about as a convenience, and that hospital doesn't indicate this was for an emergency, I don't think the city's plan would pay for it, and the city's not self-funded, I don't think. Is that right? They're a Blue Cross Blue Shield? In which case, they're dealing with the insurance company. They're not dealing with Titus County dollars, and they'll deny that claim in a heartbeat.
Okay, we have $4,500 deductible, right?
Well, that's maximum out of pocket for an employee. Our deductible is $850. But if that employee has a major medical problem and they pay their $850 deductible and they pay that 20% copay, and it gets to where they've paid out so much, when they hit 45, that's it. That's it for the year.
So it wouldn't be possible they're going to emergency to avoid getting to that 45 quicker, or would it save them anything?
Well, that's what that report she's talking about is going to show us. No, I don't. You see what he's asking there? I don't think that would be a danger in our plan. Because we don't have any more. It's not. There's no benefit to the employee to go to the emergency room.
No, there really isn't. No, I mean,
they're going to pay a nominal $100, but that's a high convenience fee. But sometimes there may be somebody willing to pay it if it's 2 o'clock in the morning.
Right.
But we're going to be the ones that get paid 10 times that.
Absolutely.
That
Yes.
$100 doesn't go to apply to their maximum of out-of-pocket $4,500?
That $100 copay does apply to your out-of-pocket, yes.
Yeah. And I'm seeing more and more of this, but it was probably 15, 16, 17 years ago. We had a limb hanging. It was between the ditch and the road. And so dummy gets out, and I jerk that sucker, and it falls and knocks me into a fence, and I get cut in the mouth. I have to have about 4 or 5 stitches. I just go, and I go to the doctor, and I walk in, of course, blood's all over the place, and he said, "You need to go to the emergency room." I said, "Can you sew me up?" And he said, "Yes." I said, "Sew me up. I'm not going to the emergency room." And I've been very blessed, and I understand this, but I've never used the emergency room. If there's any way a doctor can fix me up, that's what I'm going to do. But there are people that I think you're right. They go to the emergency room because it's the weekend. You know, they run out there and it's really not an emergency where they could go out here, and I don't know if that's a lack of educating our employees that you need to use this facility.
Or, you
what?
put Teledoc in place in January, so and it's being underutilized. I mean, just hardly no one is using it. We're getting monthly reports and there's just no utilization. Once I get that emergency room report, if there is high utilization for non-emergency use, we really need to figure out how we can tell them to stay out of there. I mean, if it's a weekend or the middle of the night and it's something like a sinus infection or your bladder infection, they can call Teledoc, and that doctor can call in a script for them. And so they don't even have to leave their house other than to go get their pharmacy. So we've got to figure out. So I don't want to speculate until I have that data.
Okay. When are you supposed to get that?
Drill down even further.
When are you supposed to get that?
Anytime now. I should be able to have it within a week or so.
You know, if you're having chest pains and stuff, that's an emergency as far as I'm concerned. If it feels like a heart, you think that's what it might be.
Absolutely.
I don't have a problem with that.
Yep.
When you've got the flu, and you go to the emergency room, unless you're dehydrated, and it's a bad case.
Absolutely.
And I think parents or patients would understand that. But
well, I do know
to me, this is the place to go here if it's not an emergency on the weekend. You're not going to find a doctor probably Friday at dinner time. If something happens, you're going to have to go either out here or you're going to have to go to the hospital if it is an emergency.
Yes.
You got to use common sense and stuff on that. But,
Will the report give us direction there?
Yes, absolutely.
Emergency is a
I want people
commonly abused thing, but we don't know for sure that that's what happened here. You might have a whole bunch of.
Yeah, you have an accident and you're cut bad, or you might bleed to death, or what you call them ambulance.
We're not talking about those. We're talking about the person that goes, well, doctor's closed, let's head on down to the emergency room and get you some aspirin.
Exactly. Another trend we're seeing is more and more people don't have a primary care physician, so they haven't gotten an established doctor-patient relationship. And so they're using that emergency room for that type of service. And we've got to get them to use that primary care doctor. You know, establish that relationship. Get out there and get that appointment, whether you start out with a wellness physical and then you can go to them for your colds and flus and, you know, urinary tract infections and things like that, and that will allow them to stay out of that emergency room.
Well, let me ask you this. If somebody goes to the emergency room with a genuine emergency versus a convenience, they still pay the $100, either one of those? So there's no differentiation in the casual user versus the emergency?
But that is a benefit design we can put in place. I've got many clients that put in a $100 copay for a true emergency, and then it's deductible co-insurance for a non-true. And like I said, we do have the determination of what's true and what's non-true. Absolutely. That's a great plan design that's been very effective.
Let's make a note of that.
Okay.
That we want to do that, and we may want to hit hard on that. But again, let's don't jump to conclusions till we find out what's the nature of these emergency visits.
Absolutely. All right. There wasn't much else that I wanted to, show you or talk about in this page. Moving to our preventative screenings on page 10. Again, this is where you'll look at the first table. This is where the report was run on a rolling 12 months. So it starts in April of last year and goes through March of this year. So to what I said earlier is, don't look at these decreases or drops in your utilization of your preventative as a negative, because most people don't necessarily run right out at the beginning of the year and get their physicals or their annual exams and things like that. They tend to do that later. I myself have got it now where it's done in the summertime. Don't ask me why. It's just one of those things that I get my kids' physicals for school and then I do myself. It's timing. And so the next preventative screening norm, you'll see down at the next table, as I said earlier, you're exceeding UMR's book of business and everything but the colon cancer screening rate, which again, those generally are only performed once every 5 years. So a drop in this rolling 12 months doesn't mean that no one's going to be getting it. You might have had a spike last year, and they don't have to go back for another 5 years. Because people don't abuse that particular benefit. And then going to your network utilization, which is on page 11. Your utilization and discounts. So on the right-hand side, I do have some concerns because the utilization of using in-network providers dropped. Now, there could be a court, you went from, at the bottom it says the total, so you had $513,000 of total in-network dollars, and $34,000 were out-of-network. The two categories that spiked up were your outpatient and your physician. Those correlate to emergencies. Emergency room doctors tend not to be in-network. They don't contract with any providers. And if there are some of those standalone emergencies that are not contracted, that's what made your out-of-network utilization drop. So you went from having 99% of your population staying in network down to 93%. So again, when we get that ER report, I think we're going to see why that out-of-network utilization in your drop.
How would the county employees know if that person did that work or not?
On the emergency room, they don't. And that's a category and that's an area where I don't want anyone to worry about, because you don't have the ability to lay in the emergency room and say, hey, Dr. Smith, you in my network. Well, if you're not, I got to see somebody else. They won't do that. You don't have that control. Your benefit is that doctor's out of network, but we pay it at the in-network level because we're not going to punish the member.
Why can't we tell the hospital
We're trying. The hospitals no longer have a contract with those doctors. They're out on their own. They've carved them out for expense purposes. No, it's every hospital.
Does it cost too much for them to employ emergency room physicians themselves?
Yes. They carved that out probably, what,
3 years ago.
Yeah,
3 years
5 years
ago.
ago.
So there could be one doctor that works for that emergency room clinic that's in network and another that's not?
Absolutely.
Wow.
Generally, there's not anybody that's in.
They're generally not.
Because it's literally a separate company that operates an emergency room for the hospital.
I have a hospital client that's out in West Texas that doesn't own any of their doctors, but they're trying to get us, United Healthcare Networks, to negotiate with their emergency room doctor group, which has its own tax ID and it's separate. And our network folks are going on 2 years negotiating with these ER docs. They're wanting ridiculous rates, and we're like, but we can't justify paying you this when we're paying primary care and specialty doctors this. And so they just know they have that market niche.
Wow.
So we still, I think your employees for the most part still do the right thing by staying in network, but I truly believe when I get that emergency drill down report, that's going to see why your utilization dropped off. And if it's for non-emergency, we've really got to hit that hard. We've got to keep the employees and their dependents out of the emergency room if it's not necessary. Because you'll see down on the next table your average discount. Now, you still continue to have really great discounts with United Healthcare's network. Last year at this time, this is where I'm going to do a promotion. And you've probably seen the commercials or all the banners or everything, but effective 5/1 of this year, United Healthcare Networks made an agreement with ETMC Tyler, and they're now on the network. So last year at this time, you had a couple of members that were using ETMC for different services. That's why that average discount was only 30% for United Healthcare's network. It went up to 52% for this 3-month or 6-month time period. And some of it is due to ETMC. We thought we were going to lose Mother Francis from it, but they came to the table, we negotiated with them, they're both contracted, they're both signed, sealed, and good for about 3 years. Now, we don't have that issue any longer.
Well, am I reading this correct that 2 years ago, when I'm looking at the blue graph, my utilization 100, 100, 98, and 100, we had people really being good about using in-network?
Mm-hmm. Absolutely.
We're going backwards.
Yes. Yep, we definitely are. And the two categories, again, like I said, were the outpatient services, that's where your standalone emergency centers fall, and then your physician services, and that's where those emergency room doctors would fall.
Well, surely that's some of the explanation is this explosion of these, on the corner emergency rooms and urgent cares that we're starting to utilize. Right. And we think we're doing the right thing by going to them, and we're not.
And the thing is, I'm guilty. I thought I was doing the right thing by going and using one as well. And then I get a bill and I'm going, wow. So it's hitting everybody, even those that are in the industry. And because the message that they're portraying to everyone is, yes, we'll
low-cost alternative.
Low cost, you don't have to wait forever to sit in the emergency room for 7 to 8 hours for that, that migraine you think you have or something like that. Then it's become a convenience factor, and so they're going. I used it one time, and it got me, and I have no copays on my plan. I'm done. I've got my primary care doctor, and we just rolled out the telemedicine for United Healthcare employees.
I could swear I thought Guaranty Bank told me that they were now, you better be inpatient if you expect us to pay anything.
In-network?
Yeah, in-network, not inpatient.
Oh, I've got several plans that have removed out-of-network benefits altogether.
And the fully insured United Healthcare plan is going to, it's called an EPO. Right. And that is very, very common because with United Healthcare, basically it's the Choice Plus network, which is what y'all have. If you have an EPO plan, it's called Choice, but it's the same doctors. It's just you don't have anything if you choose to go to a doctor that's not in United Healthcare's network. With absolutely no benefits, and that may be what they have. The meeting I just left this morning, that's what they're doing.
I have a
Guaranty Bank? Oh, okay.
I have a city that.
So they said enough of this out-of-network stuff, we're
Well,
gonna,
they had 98% network utilization, and we actually had a report that showed exactly where they went. It was random claims, and they said, hey, they can change. We're going to an in-network plan. The same money.
y'all understand that? You know, if you just, you know, if we get to the point where we can't keep them out of the out-of-network locations,
And what I'll do is I will do a drill down on all your out-of-network charges, not just the emergency room, so we can see where all the out-of-network charges are as well.
Well, that's what I was gonna ask. You know, you may be here or somewhere over there or something, and you don't know that this is in network, and it may be an emergency, it may be a car wreck, it may be a lot of different things.
But if you're knowingly
It may not be where they wanted to go, but they don't have the opportunity to say, I don't want to go there.
With their smartphones, they can go online and look up the plan.
But I'm saying if something
emergency
happens.
situation in the scenario you gave, that actually is a benefit design that you've got that covered. I'm talking making a conscious effort to go to your doctor that you want to see just because you want to see them and they're not contracted with the network.
Right.
That's where that person should think about the plan, you know, themselves first, but also the cost. How's that affecting me, my family, and my plan? Because when you have to make plan design changes, that's one of the messages as to why. What happened? What caused that decision to make that benefit design?
I don't think any employee, unless those of us that are plugged into this are considering the cost of the plan.
Most people don't, but it's something that I'm trying to bring up all the time, just to get it across. I mean, my husband, it took me years, but I mean, if we've been married 21 years now, but he finally gets that he will ask those questions before he just goes. In the past, he would just go. Usually, I always had to go to the doctor when I was out of town, so I couldn't control him or rein him in.
If it's not an emergency, I'll call you. You'd say, you know, this, can we go here or there or so forth.
Yeah, calling UMR, I mean, we'll help you find an in-network doctor.
And to me, we really need to encourage our people to do this. Now, why they're not doing it, I don't understand, because I know I do.
Well, I'm surprised because last year you were 99%.
I know.
You know, so there's something, you know, maybe unusual
we've gotta
about
know.
this particular period. I don't
Maybe
know.
it's somebody that has come out of network in the past year, and that's what the report's going to show.
But usually when there's a big hit like that, I will get notified, and I would definitely notify y'all. I haven't seen, we've had positive versus any negative.
What can we identify? Who we can identify?
Well, it's just ETMC Tyler. Let's ask about Pittsburgh.
They recognize it.
Yes, we did.
So let's make sure.
It is weird, it's strange.
Okay.
Now,
Okay.
don't y'all have an agreement with Pittsburgh?
ETMC Pittsburgh.
Yeah, I
So now, every, hospital here, Pittsburgh, and ETMC are all in network.
Absolutely.
Who are some of the major players that are not in network? Mother Francis?
No, they're in network.
They're in network.
And in Longview, we've got Longview Regional and Good Shepherd. In Hopkins County, we've got Hopkins County Hospital. So I don't know where there's a hospital.
I can tell you. That's the thing about it. I saw this morning, their out-of-network utilization with the Choice Plus plan. It was a doctor here in town that's not affiliated with any network, and it's a urgent care center in Paris that's a Solace clinic. They had 2 PAs that were not considered in the United Healthcare network there. And the rest of it was lab work and was a inpatient mental rehab situation, and that was it.
Would it be possible to identify the doctors and the facilities that are costing us big bucks and get that information out to the department heads and say, if you go here,
The report I saw had the provider, the amount of the claim, and the number of visits. It's probably exactly what you.
I know we can't go to that employee and say, you need us to quit going there, but we can put up posters and say, if you go here, you're going to start paying heavily for it.
And a lot of times what we'll get is the legal calls at the office, like I said, well, they said that they accepted the insurance. Well, that's kind of a, play on words. And everybody accepts your insurance, but whether or not they're a provider in that network is a whole different question.
Right.
So if you walk in and go, hey, do you take United Healthcare? Sure, we take it. We take X, Y, Z, we take it all. But the question should be, are you a provider in network? In network provider.
Let me ask y'all this. You said lab work. Didn't we rectify that last year as far as?
Your benefit, but where it was performed at, yes, but we're still seeing doctors who are contracted, and United Healthcare Networks has sent out letters over and over and over of those providers that are still sending to Quest.
But what we fixed, you fixed your plan where you're not getting penalized
Okay.
for it, but the plan's still paying the difference.
Okay, all right.
Yeah.
But
The members are not seeing that as an issue on their end.
Well,
Well,
I was under the impression that it would, but, okay,
Yeah.
all right.
We still have those
What was your
doctor's offices that are lab work out.
Yeah.
Last year we
Yeah.
talked about rectifying the lab work. Well, I thought that would
Yes.
count for them being in network, but it doesn't. It's just, it would pay, but they still send them out to doctors out there.
Who's sending it to doctors out of network? Your family practitioner?
I assume that's, is the lab work, they send it out to the doctors, or the hospital sends it out to these.
It's more, not so much the hospital side of it, just because they have their internal pathologists who can read it. It's more on the doctor side. They draw your blood, they'll send it to a person that will run the lab tests they want and then read it and then give the doctor the results.
Okay.
And contractually, they are supposed to use in-network labs. That's in their contract that they sign with United Healthcare Networks. But they also use every other carrier, and each carrier is different. I know for a fact that my doctor has a big note in her each of her patient rooms that says, Aetna uses Quest only. All other carriers use LabCorp. They've got stickers on their doors because it is hard to remember. But I do this every day. When I go see my doctor, I made them put LabCorp only on my chart, and I made her highlight it and put it in big bold letters. Because first time I went there, they sent my LabWorks Quest, and I came knocking on their door. Because I had a $700 bill. And said, no, you are contracted, you are required to send it out.
I think my doctor sends it over to the hospital.
Okay?
So the hospital is in network.
Yes,
But-
and that's where we changed your plan so that you wouldn't be dinged on the
Right.
deductible side.
But a lot of times the hospital sends it to Greenville, and that guy's not in.
No, he's not. I've had trouble with him too, so.
Yeah.
But,
You know?
yeah, a lot of,
Are you going to tell him not to send it to him?
I don't know, he can't.
You can ask.
well, like what you said. Well, no, but is there any way we could do that? Yeah.
I mean, you can always tell your doctor that and mention it and see what they'll say.
But that's the hospital doing that, that's not the doctor.
Yeah, the doctor's sending it to the hospital, which is the right place because it's in
Right,
network.
right.
Where it goes from there is out of the providers, out of your doctor's hands. Then that's the hospital that's violating it. Is that Patch Regional doing that? Okay.
Well, if it leaves this hand and goes to this hand, you better check to see if you're in
Wait a
there.
minute, does
You
Titus, I
don't, it may end up somebody you don't know where it's going.
think Titus Regional, the LabCorp is in the hospital up there. They got a space in there.
LabCorp does?
Yeah, in the hospital, so
Well,
are
that's,
they using
Tony, do you
LabCorp?
know that? Is LabCorp located and do they have a affiliate here in our hospital? He's thinking he saw LabCorp's name there.
They have full cars and they drive around and they pick up stuff.
Yeah.
Very rarely do you have an office to let.
Right.
Okay.
You don't think they have a little room there in the hospital?
They might. I don't know.
Well, I know We had a situation where we'd send the lab work, Dr., I don't mind telling you, Dr. Williams' office, they have people that they could do that particular lab work, but they had to send it to the hospital. But I think y'all got something worked out now.
Yeah,
Your plan changed.
yeah.
And where they could do it there at Dr. Williams' office.
Yes.
This basic stuff.
Yeah, what I'm talking about is the hospital will send out a lab to another doctor in Greenville.
Yeah.
And it happened to Philip, it happened to Christie, it's happened, I've seen a couple of claims in the past month. And we don't know that. We don't know where they're sending.
You don't know where they're sending it to.
Why can't we tell the hospital that if you do something like that, we're not paying you?
We're gonna, I've written it down to have our design, our contract negotiator with the hospital. She's in my office, and her and I have been working with the hospital on some
And it may be
things.
that this guy's the only one that does particular tests. I don't know.
I don't either.
My tests were just regular checkup.
I know.
Check the thyroid, it wasn't anything unusual.
It was the same thing, wasn't it? Philip? It was-
Yeah, and a couple of my guys out there, they had the same thing, the same
The claim I saw
doctor.
last week was actually another, was not affiliated with y'all, and it was an emergency room visit where the person was taken there and then airlifted. But the same situation happened, totally not in the network, and that was with Blue Cross. That tells me he's not in UHC and he's not in Blue Cross, he's probably not in any.
Probably not. So, to be conscious of everyone's time, because I know we got a few other things to discuss after the reports, I've provided or brought with us today an OptumRx report. And I'm not going to go through every single page in this because there's some pages that don't have any information on it. I read through the report and I've got a few recaps I'd like to point out for potential recommendations and things to think about and look through. Your member cost share of what they pay for their prescriptions on the copay level versus what the cost is to the plan. Everyone had one. Oh, sorry, Steve, I didn't.
That's all right.
What the cost to the plan is lower than our norm. Our norm is that usually the member cost share is between 15, 20 to 22%. Your member cost share is 9%. Now, your copays, I think we did some changes on that. We have a $5 generic copay, which is great. That drives utilization to generics. Your brand is $25. Your brand non-preferred is $50, and your specialist copay is $150. I did not see a lot of overutilization on that specialty copay, which is good because there are so many new drugs that have come out that are falling under specialty that are tens of thousands of dollars.
I'm not addressing the single source brand.
We have that capability.
That's one thing I think you need to really be talking about. And what I mean by that is there's only one manufacturer for a drug. And because of that, they can jack the prices up. You ever heard about the Wall Street guy that was charging like, what, 800% for an AIDS drug that he was the only manufacturer for? What I'm seeing from other TPAs and other insurance companies is that they're literally going to a closed formulary, where if it is not on the list, the drug is not covered. It hit me. I mean, I will tell you, my doctor said, you need to have this prescription, and Blue Cross said, I'm not going to cover it. Blue Cross has already done that. But if you look at this list and you see how much certain drugs cost, it will literally float your boat. And some of those may be single source brand drugs.
In other words, we might find ourselves saying, if you want to cure your hep C, we're not paying for it.
Right. Well, not necessarily that is, there's this other treatment or this other prescription that's been out there for a longer time. You're not going to get that Harvoni right now because you just got diagnosed with this. If you haven't tried these other things, it might take care of you versus going straight to that one. We are rolling out in the past, OptumRx to our self-funded customers have really had the option to do a closed network, but now we're really, really drilling down on it. I will ask for a cost analysis because not only will you save it on your, you get a rebate fee credit off your admin fees, that could potentially double. And also I will ask what the cost analysis is based on your plan and what drugs the members are using, what kind of savings as a whole to the plan it would be as well. But no, there is some noise factor when you do a closed formulary. We would identify any members that it would affect. We could identify them. We could work with them to try and get them and their doctor to a different prescription. There's lots of proactive measures we can take. I just want you to know we'll hear about it.
But direct them to the sheet of page in the report that's got the cost per
Sorry.
Is that on the Optum report?
Yes, it wasn't in a bind, yeah, it was your OptumRx report. And what this is showing is it's your second quarter, so it encompasses first quarter, second quarter of 2016, but it's also showing you some 2015 results as well. Generic utilization, mail order utilization, your specialty drug costs, again, there was none. But here, go to the page that says top 20 therapeutic classes by drug cost.
Fourth page.
You either go to the next one, you can look at that. Yes. Actually, the next one is good too. It's the top 20 drugs by drug cost. And instead of therapeutic, meaning what diagnosis category, just go into the next page, which is your true drug cost. And you can see that the top drug, and I haven't even heard this, so I mean, it's not being run on commercials, yeah, advertised, but it's a non-narcotic allergenic, and the average drug cost is $11,024.
Is that per what? Per
That
90-day
is-
prescription or what?
That is for six scripts, but that's a per drug cost.
That's per drug.
Per drug.
You're charging them $50?
Yes, and that's a $50 copay for your members. The plan picks up the difference.
So that $137,000 that you're spending on drugs, it's a whole bunch of it back. And it doesn't get any better as you go down. The next one's $72.97.
And then the other thing that I noticed was, it also shows you your top pharmacies and what their drug costs are. Is clinical pharmacy, is that a hospital owned or is it a standalone?
Standalone.
It is your top pharmacy,
Always has been.
and their costs are $46,000. The next pharmacy down below was American Specialty Pharmacy that only charged the plan $5,600. So you went from clinic pharmacy, they're very expensive. All of their drug costs are really high, much higher than these other pharmacies. Which one? Okay. So
That's somebody getting probably these and
Right.
over the.
I apologize, I thought it was in Mount Pleasant, but the next one down is only about $5,000. So,
Well, yeah, but there's a lot fewer prescriptions.
It's because they got 369 prescriptions.
yeah, that is a highly utilized pharmacy.
It's 52%.
Why are you,
It's in the hospital.
why are you saying that it's
It's
so
just,
much more expensive?
well, more people are using them, but their costs are a little bit higher. Generally, when you have a pharmacy that's in the hospital, they have, their contract allows for them to be, unfortunately, a little higher. If we can get your members to use pharmacies that are not that one, you might think,
Okay,
the plan.
are we still talking about clinic pharmacy?
Yes.
Okay, Steve, you made some comment about it's in the hospital. That's
I
not,
didn't, he just, no, that's perfect.
Oh, it's a standalone?
no, that's Jim Webster.
Jim Webster.
I don't know which one of these is in the hospital.
369 scripts.
Yeah.
It's just because of the numbers.
It just goes to the numbers.
Yeah, they just used it.
So are we unfairly labeling them as an expensive pharmacy?
That's what I was thinking. That's what I was looking at too.
Most people go there.
There's a majority of, that's where the majority of people
Because the
go.
next one down.
Well, the reason most people go there is because they established that habit
Yeah.
here with Health First, and they give quick, fast service. They're easy in, easy out, and we've encouraged people.
369 prescriptions.
Right.
Right, and I would expect it to be that high, but is there a reason for directing people away from that if
No.
they're,
And again, Blue Cross has got to where, they're doing, I know, you want to talk about that, but they're doing more stuff on pharmacy than anybody else. So they're directing people to CVS, Walmart, Sam's, Walmart.
Well, our mail order is the best way to go. I switched all mine.
Yeah.
What?
Yes, that's it. Your mail order utilization is non-existent.
I'm one of them.
And it's become so much more convenient. I now have to take a drug every day, and our plan, you can get one retail fill, and then you have to go to mail order, or I have to pay the entire cost of the drug. So I got my retail fill for the first month. It was $27. Not bad, but still, $27. I signed up for mail order, and it was so easy. I went online and said, I want to do mail order for this prescription. They contacted my doctor and said, Chris wants to do mail order. Will you write a script for 12 months? And she said, yes. And I got my script. Boom, they sent it to me. I went from paying $27 a month to $4.87. It's a significant decrease.
Well, it hasn't
in cost.
changed my direct cost that
Your
much.
mail order is, and excuse me, there's 5. It was 2, you went to 5, and it's on the second page. Mail order, mail service utilization.
Page 5 of this.
No, second page.
2.
They're not numbered, unfortunately, so this is the front
Mail
page.
service utilization.
So mail order is something, again, your co-pays are set up that mail order is 2 times what the retail is, but you get a 90-day supply. So they're getting 1 month essentially free. It's just, how do we get people to understand it is convenient?
Well, it's not simple, I'll tell you that.
Well, I've never done it myself until I had to do it last year.
It's not the best laid out
You don't
website.
think?
No.
Okay.
And I can show you why. It's not user-friendly.
Okay.
And then they force ship you every 2.5 months rather than every 90 days. Well, that makes no sense. Why do I want it every 75 days and not 90 days? I'm just going to be building up inventory. So I said, take me off auto ship. I'll order it when I need it.
Oh, okay. So more than likely, the reason that they were sending it every 2.5 months is so that you didn't run out. So if you got down to the very last day, you had your script.
Well, they ought to be able to figure that out the first time I order. I'm sending you 90 days. I'll send you the next one 2 weeks before your 90 days. But don't send it every 2.5 months.
I don't know. I appreciate the feedback. I'll share that with the Optimum RX side because.
Well, I can tell you one thing. If something comes up and Sharon has thyroid problem and stuff and she forgot to get medicine, Jim will come up here and meet me and give me the medicine. I come by today. So it's that convenience of something like that. And he does that extra for me.
Well,
And we're
so
paying
for
for
an
it.
example, what the judge was saying though is every 75 days, he's getting a new script filled because they don't want him to go the full 90 days and run out. So there is, but he had the ability to turn it off with automatic refills. I have mine set up on automatic refills. I signed up for text messages that said, we're going to ship your drug in 5 days. And I'm like, okay. And then when they shipped it, they said, we've charged your HSA debit card. But I set it up that way. But you can set it up to where you go in and say, all right, I need to have my refill done and have it sent to you. So for that example, she could have it set up to where she gets her mail order and she gets it every automatic refill, and we only let it go to 75 days, and then we're going to send it out again. So you're going to have your new script before your old one runs out.
And then the next month, you're going to have 4 weeks left of medicine. And then the next one, I'm going to have 6 weeks worth of pills left.
So basically, I think our takeaway from this is we're going to possibly be back like maybe 1st of September.
Yes.
And get options for maybe looking at ways to save some money on the pharmacy plan. It may not be a closed formulary, but Chris is going to give you some prices for that. And maybe some other options in between.
Right.
So,
Yep.
if we
Get
can
with
look
Elbert.
at, if we can look at a report that actually shows what the member's paying for a prescription and what the plan is actually paying, that $11,000 is a great example to kind of see. And like I said, going down that list, the next one is $7,000. I mean, that's a huge thing to see. Is it possible to, and I know it is, to go to a...
But the cost to the county when we mail order, there's a significantly less cost to the county on a mail order drug.
Absolutely.
Well,
Because you're using OptumRx's batch of drugs.
then somehow, some way, whether by force or whether by otherwise, we need to start converting people over to mail order.
Please correct me if I'm wrong, don't they, if there's any sort of a maintenance drug, can you make them do that now order? Yeah. But and what blood pressure, cholesterol, something that everybody gets every day, there is a way to say, you get a copay if you use mail order. If you go retail, you're going to pay more for it. If you know, and that doesn't apply to things that you just get diagnosed for. You
Well, paying more for it is one thing. If it's, I'm going to pay 25 over 10, that's not much of an incentive to force somebody to switch over.
We just need to see options and to see how it impacts the cost.
But we do well to hire somebody to come in here for a week and sit down with every person in the county and help them set up their mail order, because they're going to need help. I experienced it. It's not, I wasn't real impressed.
Okay. See, I had never used it either, and I had a different experience. I mean, I went online thinking that I was going to have to get my doctor to write me a paper script, and I was going to have to fax it in or something. And when I went online to do it, and we have OptumRx too, when I went online, I was putting in what the drug was and who my doctor was and, you know, the milligrams.
That part of it worked okay, but every time I log in, it's like, hey, Brian, would you like to use OptumRx to get your meds? Yeah, I'm already with you. Why do you keep asking me that?
So it's not recognizing you as an existing patient?
Well, no, it is. It's got my prescriptions in there, and maybe it's because I turned off the auto ship feature. But I set up all four. I've got a couple of nasal sprays and a blood pressure and a cholesterol. That's it. Okay. And they're all just repeat. I just want them set up, but I don't. But as soon as they told me they're shipping every 75 days, I said I don't want that. But I guess if it was cheaper for the county for me to get them every 75 days, I'd be better off.
No, as long as you're using a mail order, that's where it's cheaper, because we're able to negotiate a bigger discount because we're buying it in such a huge bulk versus that retail, we can only negotiate X dollars because there's so much of a difference.
Well, I see the benefit in it, but again, if I set it up for automatic and it's coming every 2.5 months, eventually I've got to say, whoa, stop shipping me this stuff.
Well, at the end of your prescription time period, because I'm at the end of mine, and I actually, with my surgery I had, I wasn't able to go see my doctor to get a new script. So in that automatic refill, I've got enough now to carry me over until I go see my doctor, which has been 65 days. So there's an advantage to the automatic refill.
Well, maybe so.
In that sense.
Yeah, maybe so.
I didn't, you know, if I hadn't
thought of that.
If I hadn't shut it off, or I had shut it off, I would be out. And I would have been forced to go figure it out. You know, it's each individual's preference, that's for sure. But let me come back. We've got a lot of alternatives. No, I appreciate the feedback, though. And good to know.
And just to clarify, too, we can't tell by looking at this that clinic is any higher than other local pharmacies.
Yeah.
Okay, they're just being used more often. If that's the
right. We know that. And we encouraged it for years.
How far are our local guys getting the business? And if folks will do mail order, fine. If they want to continue.
And I think the reason people started using him, because I think he was accepting our Health First. Maybe when he wasn't even on the list.
There was a small delay in the negotiation between OptumRx and the clinic pharmacy, so they actually were either turning patients away or charging them a non-out-of-network charge, but it got negotiated and they've got back in the network.
Okay.
We have one situation we need to discuss, and I actually have to leave here at 12 o'clock to go with the long one. So I'm just going to, and I've talked to Brian about it, and I've talked to Philip about it, and Chris and Steve know. We had a claim situation that actually we wouldn't have known that there was ever an issue with. But you had an employee that was covering a child that was like 25 years old, and the dependent child actually got pregnant and lost a baby, and the doctor filed a claim under.
It wasn't so much that, it was that it wasn't, the dependent daughter pregnancy period aren't covered.
Well, okay, but let me say this and then we'll go back to that. So apparently the guy came to somebody during open enrollment. My mother was dying during that open enrollment period, and I honestly left early, but he said he had somebody, our maternity's covered under, if I could, because she's a teacher and she had access to coverage with TRS. But because y'all's plan offers such a great benefit at such an affordable price, he decided to put her on this because he knew she was trying to have a baby, right? But apparently the way the contract reads, that only prenatal coverage is included on a dependent child pregnancy, not the actual delivery cost. But, so what happened was the girl lost a baby, the doctor's office filed the claim in such a way that UMR paid it, okay? Hospital filed it another way, and it was denied. And I'm not going to go into how they filed it, but so that's what they did realize, that why is the hospital bill getting paid? So that's when they came to me, and that's when I started digging into it. And so what it brought to light is the fact that we're allowing people to keep kids on the plan until they're 26. So obviously some of these kids are married, some of these kids are going to be having babies. So, but the way the contract reads is that only covers prenatal care only, not labor, not delivery, not actually having that baby.
On children or any dependent?
I'm just
Dependent daughters, children.
Dependent, not a spouse.
No, yeah. And obviously this has not come up much because this is the first time that I've ever known something like this happening. But I think y'all need to have the conversation. And did you get any information about that? Does it increase it?
No.
Well, okay, so let me say this. Okay, let me finish my story. So basically, I contacted your employee. He and I we talked on the phone. I talked to his wife. We all talked. And I had got the information of what it would do if y'all decided to pay that claim. However, if you decide to pay that claim, then you're paying every other claim that comes after. And you could have what's called a bad baby. That's if somebody has like a preemie, and they're in the hospital, and that could be $1 million. You could have early twins, and that could be a huge amount of money. So I think y'all need to think about when you decide what you're going to do with this claim, how, if that's opening up a Pandora's box of more stuff that could follow. So Chris and I talked about this the other day, and she was worried that it was going to change your stop loss cost, and it will or will not.
No, I talked to Stop Loss, Zurich, and it won't change your cost because what they do is they mirror your plan. What you will be required to do is you will have to then cover grandchildren because that's what that daughter's child is. So then you're opening up to allowing grandchildren, not just on dependent daughter pregnancies, but anyone who has a grandchild that they want to have covered. And that's an even more expense possibly for the plan as a whole.
So the gist is, you've never had that coverage before.
Not under Health First either.
Nobody.
No, I looked.
We just hadn't been, we weren't, when the question came up.
And
Okay.
ACA required you to cover the prenatal starting last year. That's the only reason why you have to pay the prenatal care on a dependent daughter. Before, you paid nothing on a dependent daughter
But in
pregnancy.
the past, if you recall, your dependent stopped at 19 or 21 if they were still in school. Okay? So when ACA made you expand it to 26, that really opened up that.
But you still were able to exclude the pregnancies as a whole. But then last year, the ACA...
But nobody knew that.
Right.
See, that's the whole
But
thing
it
about
was in
it.
your
Nobody
plan.
knew
It was in
that.
your plan with Health
It-
First, and then it's in this plan.
But it was told a different way. I mean, nobody,
Yeah, he said that he asked somebody to open enrollment, if I put my daughter on, will it cover maternity? And he was told yes. I mean, I don't remember talking to him again.
I probably would have answered it the same way.
Well, that's what I'm saying. I mean,
Everybody had the same benefits, but anyway, that's my error, or our error, or whoever, I don't know. It's a misunderstanding for sure. So,
But if you make an exception to allow these claims to be paid under your plan, if it comes up again, or someone finds out
Why
about
can't you
it,
just
and-
pay a one-time, hey, we made a mistake, we're paying this, but we're sticking with the
You can pay it
plan?
outside the plan, is what I was about to get at.
Okay.
And then you're not making any exceptions to your plan. Now, how you go about that, you'd have to financially within the county.
but just
But-
paying out your benefit deals, what you do.
Yeah,
you know.
so, but ULR wouldn't do it, and that way there's no
This
exception.
cost, would this cost still be the same if they did that?
Well, that, yeah, sure.
Okay, so basically, I'll just read you this is what UMR said. The dependent child would have to, still needs to meet $100 to satisfy her deductible, and then an out-of-pocket of $4,000 where the member pays 20% per claim. This is the in-network benefit if you choose to override the denial. Based on the pricing attached by the network, the dependent child will be responsible for $994.32 minus deductible and her 20%. The plan would pay $3,577.28. So $35.77 basically would.
That's on the hospital bill.
That's everything.
That's it.
What about that doctor bill that got slipped through?
Well, the plan paid that, and you have to reverse that and deny it, and then.
Find out.
And I don't have the details on that.
But that 3,600 would pay that too?
No.
No, this
No,
basically
that's just
is
the
hospital.
hospital part there.
What did we pay on that other one that really
We
shouldn't have
don't know
been
yet, we'd
paid?
have to go back and find out.
Probably not as much as the hospital.
Not much, if she didn't even meet her deductible yet. She didn't meet her deductible yet.
Well, I sure think that we need to pay that situation.
And then the employee needs to, they need to understand that there's no maternity coverage there. Okay, so open enrollment comes around, she needs to get on her group coverage
That
somewhere.
brings, I thought about this in the shower too, that actually brings up something that, y'all been really, I guess, questioning. If somebody's got other coverage elsewhere and you let them come on this plan, that's just where you're assuming more risk than, than if she had been on her plan with the school. And the only reason she was on this plan is because y'all plan is so wonderful and so affordable.
But they consciously decided, hey, let's put her on there and get that good county insurance.
So they all can go hand in hand, I mean, I agree. This guy was given wrong information. This was a
Just
sword.
yeah.
Perfect sword, But I do think it kind of leads you to think down the road, on these dependents and other coverage. I mean, y'all had that conversation, I know, for a while.
Okay, do we need to wait until you quantify for us what that doctor claim was so that we can do the two together?
Like this. I mean, she's already asked me, do I want to do it? She asked me, she said, do y'all want to reverse this claim? I said, I can't make that decision. We'll have to ask the commissioners about that. So I'm hearing you say that you do want to reverse the claim and then pay it outside of the contract with this.
Yeah, and we probably need to get that approved.
And if your total out of pocket is $4,000, this is $35.77, I'm probably thinking that doctor's bill is probably about $600 when you say, because that would be for total out of pocket.
Yeah.
Yeah, I was thinking would be less than that hospital bill.
Yeah.
Well, I mean, you can't.
Well, we can probably take action on item number 3 here and go ahead and do that.
Do what now?
We've got an action item number 3, we can lump that in there.
Oh, okay.
Are you making an exception to the plan, or are you going to pay it outside of the plan?
We're going to do whatever you said we're going to do in order to continue forward, not having to pay these claims. And I'll add that to the email to the department heads as a reminder. There is no dependent daughter maternity coverage other than prenatal.
Other than prenatal?
And that's why it didn't pop up when she started going to the doctor, because they had no clue.
Sure.
And I'm totally with them on this, that, she never knew that it was not going to be covered, because the prenatal was going to be paid.
Right.
Well, prenatal is, what does that
You go
include?
to the doctor every 2 weeks or every month.
2 weeks or
And
more.
have sonography?
Up until 9 months?
Yep.
Well, what if something odd occurs during that gestation?
Complications are not covered.
They're not covered.
Okay.
It's just prenatal,
It's
no
just the one that
complications.
doctors visit.
We're not there yet. Okay.
Having the checkups and exams and stuff like that.
Which is very, that's just weird.
It is weird to me too.
Why would you cover that part if you're not gonna cover actually having that?
All right, let's jump down to item number 3. Well, I don't know if I don't think there's going to be any other changes come out of this meeting here today, but let's jump down to item 3 and consider this special situation. I think that Commissioner Fields is making a motion that we pay outside of the plan to make whole this dependent daughter on this maternity-related claim, and that we reverse it out of our coverage payments so that we are not obligated to pay any more similar situations. So, Joyce, to try to simplify that, the motion is we approve the payment of this individual dependent daughter maternity claim outside of our health plan. And we will reverse any monies that have been paid related to this claim out of our current health plan. You want to read that back? See if that makes sense.
Clear fact of this individual and child maternity claim outside of our health plan, and will reverse any monies that have been paid related to this claim out of our current health plan.
Okay, got a motion here. Outside of the plan. In other words, we don't want our health insurance plan to pay this claim. This is going to be a special item that the commissioners are going to approve, I think, that will pay out of, an emergency item or whatever out of our general fund. But it's not going to, we don't want to set a precedent by paying for this out of our UMR plan.
And I'll have it broken down by the provider, and so we'll reverse the doctor, and you can tell me that we're going to reverse that plan, and then Chris will get Adrian to send us a breakdown. And if my thought is you don't just, well, you tell me, do they pay him, or do they pay the provider? Either way, either way.
And they not send like an invoice in total that we have,
That's what I'm saying, Andrea could do a lot of things, like doctor's bill, whatever.
and she can email it to Commissioner Hunt.
Yeah, sure, I'll get it, I'll send it to him. And then you'll have a lump sum that you can just pay him, and then he can pay the bills with that.
Now, in the future, this might be in our handbook that states.
Yeah.
More clear.
For sure.
This is anything that, your information that they don't look at, we don't have funds, where's the funds?
Yeah.
Okay, I've got a motion by Commissioner Fields, second by Commissioner Hinton. All in favor of paying this claim outside of the plan as been stated, say aye. Aye. Opposed? Okay. That passes. And then I don't feel any obligation to do any more other than perhaps including that in the email to department heads, and then we will reiterate that at sign up, that this plan doesn't cover dependent daughter maternity other than prenatal care.
What we'll do is we'll actually address that in the booklet, and I'll get y'all some more copies for your new hire, so that you'll be sending that out now. And anybody that wants to get a copy of it, I'll give it to Christie and Sharon, and they'll have that now.
Okay. All right, what else do we have?
If we're going to come back in September to discuss that.
Yeah, when is our next, when is the appropriate time to come back where we can zero in on changes?
Been doing it the first part of
She should
October,
have
haven't we?
renewal mid-September, so I honestly think, don't you need to, will you come back in September, will you have all these, the options option to
Yes.
change the prescription,
Yep.
the emergency room.
Absolutely.
How it will impact the cost.
Yes, yes.
So if we do mid-September, we're doing that.
Mid-September.
We need to have open enrollment as early as we can. Last year, it was, we could, if we could go even at the end of October, and I'm Tony and I discussed with you, I didn't know how early you could do open enrollment, but we have to have all the agreements, all the changes in their first payroll in December. So we can't go much past the first week, you know, because we have long with them behind.
Let's shoot for late October if that's doable.
And we'll have to get with Sharon, make sure she's on her payroll, but either the second, or maybe either the third or the fourth week in October, if we can do that, whichever week she doesn't have payroll, whatever it's the third or the 17th of that.
October.
October 3rd, October 17th.
Because it says it's a very bad crunch.
October 3rd or 17th.
That would be perfect for us, because the later in the year.
It's right, yeah, we can get, well, and let them start putting that on their calendar. They've already rolled back.
I would say, in case, you know,
I want to get a
if she comes back in
y'all,
September,
Richard
let's do
Jones is texting me, we approved 50 things being replaced. He's come up with 59. He's saying, do you want me to hold at 50 or go ahead and do 59 at 135 each? We approved this. I need to know if, and I'll get this approved at the next meeting, but for now I need to tell Richard something.
Oh, I'm sorry. Okay, you know, the glasses around the courthouse, we okayed up to 50 things. He's checked them.
Give me those dates once more.
59 need doing. What, we'll just text him and we'll take it through court next time, but we just need a verbal okay. You don't have a problem with getting those extra 9.
We're talking about next meeting, September 17th, right? Is that right?
Have you looked at the outside building? Look at it.
All right, October the 18th is a Tuesday. This would be a two-day?
about a day and a half.
We okayed in court, taking you.
Well, we've got court in here that day on the 18th.
We're just giving.
Now, we can find an alternative location. Well, we've got the old auditor's office that's got plenty of room in it. It's not as much room as this.
I'm going to try, we're trying to set up.
Oh, you are?
Well,
Okay.
it does work better in here, though. You have, we really can't utilize.
Well, let's just say the 19th. Is there anyone on here the 19th?
Get the windows and water.
No.
Let's just say 19th. That sounds good.
Okay, open enrollment, October 19 and 20, Wednesday, Thursday.
Also, right quick after this,
Did you say 18th and 19th?
Their budget starts September 1. And right now, you tell us like the 850 right now is what is over each employee. Do y'all see that going up? Because Jill will need to know that if y'all want to go up to 900 or leave it the same, you don't tell us that pretty quick, like right now.
Well, we go to that, y'all, let's set a date in September to get back in meeting us.
Yeah.
Oh,
Yeah, let's come, hold that thought. I've got October all day, 18th and 9th, or excuse me, 19th and 20th, and then going back to look at September,
kind of middle of it, and what do you think?
we've got Commissioners Court on the 12th and the 26th.
I think we meet after Commissioner's Court.
So the week before.
Make an awful long day for you.
You know, Brian, I'm thinking about maybe a week before your last meeting, so if you have to make if we're having a workshop.
Yes.
Then you can make,
Yes, that's a good
vote on
point.
it.
That's a good point.
Yeah.
What about the 15th and 16th of September? That's a Thursday or a Friday. That'll be after our meeting on the 12th, or we can do it the following week, the 19th.
Let's do the 16th, because we have to go back and forth a little bit.
When's the 16th?
16th is a Friday.
Good?
Is that okay? No, Friday's no good. They don't like Fridays.
Do the 15th, Bill and Ernie are leaving the paper, but
Thursday, the 15th, at 10 a.m.?
Okay.
Okay, that's just
I
about,
don't know how you're going to answer her question, though, unless you just make up your mind you're not going to go up.
I hadn't shifted gears yet. Let's see. So we're just 6 weeks away from that meeting then, right?
At 10,
To go over the next, are we going to have all this stuff we need? Okay, CAPS and UMR. That is the September, what did I say, the 15th? At 10 a.m.
You got to have for the management support, which is our problem.
And we are saying 9/15, September 15th.
Yes.
For the renewal meeting.
September 15, Thursday, 10 to noon. And then October 19 and 20.
What time?
10.
We'll say both of those. Yeah, we'll say that that next meeting like this will be 10 to 12 on the 15th of September.
Okay.
What would we do with that?
Exactly. Did you get that?
Yeah.
Today's going to be September 15th at 10.
Yeah, got it. 10 a.m.
Okay, Christie, now I'm ready for your question.
The amount that is good for each individual employee is $850. And due to operations, they budget that for their employees, posted in their budget for everyone. So we need to know if they're staying pretty quick, if the $850 is going to stay the same, or y'all are going to, what increase it? I mean, can y'all have any idea at this time, because we need to know that from children.
I sure want to find a way to stop it at 850.
You want to do what now?
I sure don't want this cost of our insurance to continue to escalate to where we're doing $900 per person. We jumped it up $100 last year from $750 to $850. If we can't keep, we must keep this.
This is right, we have to. I mean, right now, they've extended the Cadillac to...
Yeah, but that puts you over the Cadillac threshold, even though it hasn't kicked in yet.
What's the Cadillac?
Cadillac tax, if it's over $850 per employee,
Right now,
we're at it right now.
We need a motion to make it, we want to handle it now? Want to make a motion?
No, we're just telling her, she's just trying to tell probation how much to budget for, because they pay the county, they reimburse the county for what we pay for their employees. I think $850, we'll have to figure out a way, when we have our next discussion, how we're going to change up our plan where we can contain our costs.
For their purposes, we can say, so children is just going to be the $850.
And then we'll be dependent upon y'all to help us figure out how we're going to contain these costs. This was a disappointing report for me.
Well, we've added people on. More money coming in. What I want to know, the total cost percentage-wise compared to the amount of people that was on it last year and the total cost percentage-wise for the people that was on this past year.
You've got that.
It was up 56% or something like that.
Yeah. And the number of people on the plan certainly wasn't up anywhere near that.
No, only 6.7%.
I hope maybe it's just an odd year. You don't have those. We've talked about that before. We've been running pretty good the last you know, a couple of years.
Yeah, but we're seeing some trends in some areas that are
Yeah.
getting out of hand. Prescription drugs and out of network and emergency. And if we get a handle on those, maybe we can
I
do
think we
this.
can get a handle on that. That's what the next thing I was gonna say. we need
But in
to-
order to do that, we need to be prepared to make some potentially difficult decisions where we're going to limit drug availability, we're going to make heavy penalties for emergency room use, and what was the other
If
one?
it's not emergency.
If it's not emergency, right. And heavy penalties for out-of-network utilization.
You go to out of network now, it's not, you haven't been trying to find, because right now with East Texas Medical Center and all that in there and the surrounding hospitals,
Yeah, is there,
the only exception I could see if you had a heart attack in New York.
I mean, there's no insurance companies out there that are giving you a wider in-network than UMR. Maybe there, I mean, maybe there's a, maybe there is, but we're about as broad as it gets.
And it's, that did broaden it big time.
All right. Is there anything else? Any questions from our audience? Okay. All right. Yeah.
Do you pay extra for the wellness program in any fashion?
100% coverage for wellness. 100% coverage for their wellness coverage.
Are you talking about from an employee's perspective or from the county's perspective?
Yeah.
The county's going to pay 100% of the wellness fund. Is that what you're asking? I'm not sure.
No, I'm talking about the wellness program.
Program that talks about staying fit, keeping your BMI, there's not a program per se in place at this moment.
But that's what I did say, if you recall, that since we are now putting part back in, we actually have a wellness department that can come and I'm actually going to ask her to come to that meeting on the 15th to actually come and talk about how we can and do, and she always does.
There's no cost to the county.
And if anything is implemented, there will not be a cost to the county. If any cost actually implements a wellness procedure as well. That's something that.
Need a motion?
Through the agency.
Okay. I got a motion by Commissioner Fields to adjourn and a second by Commissioner Kenton. All in favor, say aye.
Thank you, Joe.
Yeah, I already